Okay, so I'm going to welcome all of you to our next talk. It's by Christina Bebb, who is our physical therapist at the Cleveland Clinic in Medina, and she has a special interest in Parkinson's disease and is a wonderful therapist if you're looking for one. And so she's going to talk to us about improving walking and balance, and then also some programs that are available at the Cleveland Clinic Medina.
All right, can everyone hear me okay? Good, I see a thumbs up in the back. Excellent. So thank you, Shannon, for introducing me. As she mentioned, my name's Christina Bebb. I'm going to be talking to you about ways to improve your walking and balance and some common walking and balance issues that affect people with Parkinson's. So that's what this next slide says. So why does this matter? Why is this important? I hope this is obvious. However, if you're not sure why your walking is so important, I'm going to tell you. So obviously, this is your independence. This is your way to continue to be independent and not as reliant on your caregivers. Walking is involved in almost everything we do. So going to the bathroom, getting out in the community, going to exercise classes. If we struggle walking, we may participate less in those tasks. Our confidence, if we are not confident in our walking, again, we are less likely to participate in tasks, especially in the community. A lot of my patients will say this is their number one goal: walk better, fall less, and so that affects our quality of life. Sometimes it's relief for your caregiver. If your caregiver has to help you walk, that's one more thing they have to do for us. So let's work on our caregivers. Number one goal as a PT is to help reduce falls. So if we walk better, maybe we might be less likely to fall. And I always tell patients quality matters. It's not just about walking, but walking well. I do think it's important to note that if your walking issues are related to your medicine, so maybe wearing off, taking longer to kick in, dyskinesias, you may want to discuss that with your neurologist or movement disorder neurologist to see if there needs to be some adjustments made. Therapy can still help with these issues, but I can't change your medication or change your dosing schedule. So that may play a significant role in your ability to walk and move better. Okay, so I'm going to be highlighting several common walking issues that people with Parkinson's experience. You may have one or more of these problems. So I'm going to give you actual quotes from patients, what they have said to me, and how we can fix these problems. So this is the first one. My family says I shuffle. Or the family member says, I can hear him walking down the hall. Okay, maybe some of us have heard that before. So what's going on here? This is an example of hypokinesia, or a fancy way of saying small movements. This would look like small, short strides, a lot of times combined with maybe a little bit of downward posture or always looking at the ground. So maybe like this. Sometimes it may not be that severe, but it's smaller than normal walking. Okay? So what causes this? A lot of times I see this in patients who are unaware that they're even walking small. That's why I said, my wife says I shuffle. And then I usually follow up with, do you think you shuffle? Nah, I don't know what she's talking about. So it's very important to recognize that this is happening. Sometimes it is more common in small spaces, tight spaces, like in the bathroom, in the kitchen, where we're doing a lot of turning, where there's not a lot of space, maybe a crowded restaurant. Additionally, my patients who are stiff tend to have this issue. If we are stiff, it's hard to move. It's hard to take those nice big steps. And again, if we're looking down at the ground and our posture's forward, mechanically, I can't take a big step. My hip doesn't move that far. So what do? As I mentioned, if you don't recognize you're moving small, you're not going to fix anything. we need to recognize that we're walking improperly to make a change. So recognizing the problem is first. Trust your husband or wife or daughter or son when they say you're moving a little small. They see you from a different perspective. So if any of my patients who are here, they have heard me use this word, think big. Big steps, long steps, pick up your feet. That is a number one strategy you're going to see through almost every one of my slides. Thinking about taking a bigger step can go a long way. Additionally, we want to stretch, work on posture, address that rigidity, and if you can, make your environment a little bit better. For example, maybe move the ottoman a little bit so it's not in the way to get to the couch. Or maybe we can move the kitchen table and make our room a little bit bigger for our walker so that we feel like we have a little more room. All right, next. It takes me forever to get where I'm going. My husband or wife is always up in front of me, ahead of me. Okay, maybe some of us have experienced this. What's going on here? This one and the last issue go hand in hand. Bradykinesia or slow movement, slow walking. So again, we see slow, small steps. Sometimes this is added with slow to get to going, slow getting up from our chair. So if we're slow to get up, we're probably slow to move as well. So what's going on here? Again, if I'm taking little steps, it's going to take me longer to get where I'm going because I have to take 20 steps instead of maybe 10. Again, if I am stiff, I may be slower to move. The additional one here is sometimes if I have to think about my walking and I'm thinking about each step, that takes some time. So that motor planning or planning out my movement issue can be affected here. So what do? Look again, think big. If I'm slow to move, if I think about taking a bigger step, sometimes it gets me going a little bit. These are patients I also recommend high intensity whole body exercise. We got to get our body moving. And so sometimes getting that whole body exercise in can have a very good effect on this bradykinesia problem. And we'll talk about some ideas later. Okay? So think big. One thing you will notice on this one is I do not say walk faster. That is not the solution. And it actually usually makes the problem worse. Because if I try to walk faster, I'm still going to take fast little steps. So I always tell patients, the size is the problem, not your speed. So think big, not fast. Next one, my feet feel like they are glued to the floor, or I get stuck and I just can't move. Has anyone experienced this before? Yeah, what do? So this is an example of freezing. It's a fancy way of saying getting stuck. So this is where you want to move, but maybe your body or your feet just don't move or very, very little movement. Okay? This may look like smaller and smaller and smaller steps until I stop walking. So maybe they're getting smaller and smaller and, oh, I'm stuck. Sometimes I even see my patients get up on their tiptoes during this action. Or sometimes this happens when we first get going. So maybe I get up and I start walking, freeze. Or I'm walking and someone walks in front of me and I have to stop, freeze. So what causes this? This is more common in a change in environment. Walking through the doorways, walking in small spaces, or over a change in flooring. So going from the carpet to the tile floor. Again, small spaces, so tight turns in front of the toilet, a tight turn to sit down, another common one. Significant one here is stress or anxiety. I see a big crowded room, I'm nervous, I don't want to fall in front of all these people, freeze. Maybe I'm nervous about making it to the bathroom in time and not having an accident, that may provoke it. So making sure we're managing that aspect is very important. And again, we come back to that feeling of needing to rush. Maybe I do have issues going to the bathroom and I need to rush. Or I don't want to feel like I'm holding people up. I hear that one a lot. The people behind me stress me out. So those are all common reasons why I see people freeze. So what do we do? Lots of things we can do for freezing. I find stopping and just taking a moment when you're really frozen and stuck can go a long way. I feel it's harder to stop or fix a freeze in the moment than just stop and restart. That one can go a really long way. Maybe even a deep breath. Just relax. That can really help. Again, think big. Big steps are super helpful here. Posture. I demonstrated that person that's taking those little steps and freezes. Look at this posture. It's hard to take nice steps when I'm all the way forward. If we get up nice and tall, sometimes that can fix that freezing issue. Some other strategies, some of my patients have said if I march in place a little bit or if I rock back and forth, that they can start moving again. That's excellent. Focusing on something out in the distance. This is twofold. Number one, if I'm looking out in the distance, I'm probably a little more upright. And it helps you not focus on what's causing you to freeze. So let's say the doorway or the elevator. Look off into the distance past that doorway, past that elevator in the back. You might find that that freezing helps go away or stops it in the first place. Some people find benefit from a metronome, so a rhythmic beat or humming a tune. I like the song Staying Alive. That has a nice rhythm to it. Some of the walkers, those U-step walkers that you see around here, those can be equipped with a metronome in them. And then a visual target. So that U-step also has a laser light. Or maybe looking at an item on the floor can sometimes help. I don't like that one piece because it makes you look down. So that's good in certain circumstances. Okay. The first step is the hardest. Once I get going, I'm good. So what's happening here? This is typically my patient who struggles with initiation or getting going. So this may look like those first few steps when you get up are problematic. Difficulty starting or stopping. So again, someone walks in front of you, they messed you up. So what's going on here? Sometimes these are my individuals that really have to focus on their walking. So when something disrupts that, it messes them up. Okay. Maybe they don't know what to do mentally to help walk. Maybe it's like, what do I do with my feet? What do I do with my body? Just like freezing, stress and anxiety can play a big role here. And posture, especially getting up from a chair. If you're someone that struggles with those first few steps when you stand, next time this happens, I want you to look at your posture. So I'm sitting in my chair. I go to get up and start walking. I haven't even finished getting up yet, and I'm taking off. We got to finish standing before we can walk. So check that posture when you're first getting up and get all the way up. And also my patients who struggle with the sitting and standing task, I can't get off the couch, I can't get off the toilet. It kind of messes them up because now we're already struggling getting up and now we have to move on to walking. So working on sitting and standing can actually be a strategy. Additionally, correcting that posture, finish standing before we take off. A metronome can be very helpful here. A lot of my patients will say, I say 1, 2, 1, 2, and they can get that rhythm of walking going. I find a lot of people always have a side they start with this problem. I always start with my right leg. It's my good leg, but it doesn't work. Sometimes changing it up and starting on your not so good leg can be very effective because the good leg knows what to do. So if we start on the not so good side, and then that other one just kind of follows through. And again, think big. All right. I can't chew gum and walk at the same time. I really have to focus on what I'm doing. So what's going on here? This is a problem of dual tasking or doing 2 things or 3 things at once. So what does this look like? Trouble doing something cognitive while walking. So thinking about what you want to have for dinner, or talking about how your evening was last night with friends. Trouble multitasking with something physical, like carrying that hot cup of coffee or getting your keys out of the pocket on the way to the car. So what causes this? I find that people who have to really focus on walking have this issue. Because if I really have to focus on walking, and now I'm thinking about not spilling my coffee, which is probably going to come first? I'm not going to hurt myself. Well, now I'm not thinking about walking, and I need to. Also, it seems to be a little problematic in a busy environment. Perfect, we're in a giant auditorium of people. There's a lot of things to look at. Maybe I'm focused on those things and not what I'm doing. So what do? If you can, I always advise limit your distractions. Turn off the TV or pause the game. Don't have that conversation while you're walking. It is rude to tell the person you're with to shush or shut up. So instead say, let's talk about that once I get to the kitchen table. Speak up for yourself. Also, using items to help you with that carrying can be helpful. A fanny pack, a purse, a mug with a spill-proof lid so you don't worry about spilling your coffee. Excellent strategy. Or maybe you just shouldn't be someone that carries things. Maybe that needs to be saved for someone else. And the number one thing here should be our walking, not the other thing we're doing. So I'll say to patients, walk first, then do whatever it is second. So for example, walk to your car, then get out your keys, not walk to the car and get out your keys. So whatever it is, walking first and that task second. All right, last one. I can feel myself sway, or I'm constantly falling backwards or forwards or sideways, but backwards is usually the most. What's happening here? This one's pretty obvious. The person looks pretty unsteady or off balance. It can be in any direction. I do find forward and backwards are more common, but it can be in any direction. What's happening here? Sometimes, again, it can be posture. We have what's called our center of gravity. That's where our body kind of balances itself. It should be straight up and down. Think the Empire State Building, right? Perfectly in a line. Some people with Parkinson's are more like the Leaning Tower of Pisa. We're leaned forward. Doesn't that tower look like it's a lot easier to fall over than the Empire State Building that looks tall and strong? So we need to be upright. Sometimes I also see this with too narrow of a base of support. This is a lot harder to balance than this. So when we're standing, we need to get our feet apart. And when we're walking, we need to have our feet apart. If we're walking on a tightrope when we walk, you're not going to be very balanced. So getting your feet apart. And if you have some ankle or trunk weakness, that's going to play a role too. So what do? This goes with every single one I've talked about, but we may need a device. I see lots of people here with canes and walking sticks and walkers. Excellent. I would much rather have an independent patient with a walker than a person who doesn't want to leave their home but refuses to use a device. That device can keep you independent and keep you off the floor. Okay? Improving your center of gravity. So maybe working with a physical therapist on learning what's normal center of gravity and where you're at. Maybe we need to learn where we need to be in space. And again, working on our posture, our ankle and trunk strength, so we have the strength to balance. So you may see some of these around the symposium today: roll-itters, U-step walkers, upright walkers, canes. I really feel with devices, there's not one perfect device. They all come with pros and cons. And there may not be one perfect device for you. Maybe you need a cane when you're in the house, but a walker outside the house. Or maybe you just need a walker for at night to get to the bathroom. It doesn't have to be just one type, and it doesn't have to be all or nothing. It might be situational. Again, working with a physical therapist to find out what device is right for you is crucial. I see a lot of people with some poorly fitted devices in my profession. Too low, too big, not enough support. So work with your therapist or find one that will work with you. And I mentioned this already, but making sure your environment is free of clutter, throw rugs, phone cords. I know I get a lot of patients who are collectors. Maybe they have a lot of furniture or items, but can we keep some of those items out of our main walking areas? All right, what else can we do? Of course, your physical therapist is going to say exercise. Of course. High intensity exercise can be very helpful with a lot of the problems I mentioned. There are some well-researched types of exercise for Parkinson's: boxing, dancing, drumming, cycling. A lot of these are ones that are even involved today. There's a reason for that. They're very well-researched for Parkinson's disease. And notice, all 4 of those are pretty high intensity. There are a few programs for people with Parkinson's. So the POWER program, or Parkinson's Wellness Recovery, and the LSVT BIG program can be very helpful with a lot of those postural, stiffness, shuffling issues. So you can look those up or find a practitioner who's well-versed in these programs. And then my tips for exercise. I get this a lot. What should I do? These are my 5 tips. Number 1. Any exercise is better than no exercise. I would rather hear you doing 10 minutes than none. Okay, so any exercise is better than no. Yes, there are some better forms, but any exercise is better than nothing. I personally take frequency over duration. I would much rather have a patient exercise 15 minutes every day than 60 minutes once a week. We need that frequency. I like to recommend every day. I know not all of my patients do that, but that would be my recommendation. But frequency over duration, in my opinion. Do something you enjoy. If I tell you dancing is great and that sounds miserable, you're not going to stick with it. So do something you enjoy. If you like watching TV, park your exercise bike in front of the TV and go to town. Okay? Exercise should not be painful. I do not believe in no pain, no gain. So we don't want to make your back problem or shoulder problem worse through exercise. Yes, you should work. Exercise should be work. You might get a little muscle soreness, but there's a very fine line between my muscles are working and my back is a 10 out of 10 pain because I exercised yesterday. And let's make sure we're actually doing exercise. On a daily basis, I have this conversation with people. Walking to the bathroom is not exercise. Going up and down the stairs with 1 flight of laundry once a day is not exercise. So exercise should be time dedicated every day to exercise, and it should be somewhat challenging. Most people don't break a sweat walking to the bathroom. Maybe you do, but most of the time it's not enough. So let's set our bar a little higher than that. All right, other interventions. I know there's a lot of information on this slide. But early intervention for these problems is key. So if we can address a minor walking issue instead of waiting for it to become a bigger problem, much better success. Not that we can't fix an ongoing issue, but a lot easier to fix something when it's just minor. This is where PT comes in. So working with your local physical therapist, especially one that's well-versed in Parkinson's, can help with these issues. Sometimes my patients see me every 6 months just to make sure everything's okay. Make sure I'm doing well still. You're doing great? Awesome. See you in 6 months or a year. Let's not wait for it to become really, really bad before I get back into therapy again. Maybe I need a tune-up. Maybe I need just like a couple sessions to get me back on track. Excellent. Group Parkinson's exercise. Excellent thing, especially some of the programs that are promoted here with all the different exercise classes. Cleveland Clinic has some Parkinson's exercise classes. There are some flyers on some of the tables I know in the cafeteria that talk about all the local Parkinson's exercise classes. So these are ones that we run through the Cleveland Clinic, but there are lots out there. And then there's some Parkinson's specific programs out there. So there is the multidisciplinary program at Medina. That is a PT, an OT, a speech, and a physician, 4 one-hour appointments in a round robin. It's a long day, but you get a little bit of bang for your buck. There's the Freezing of Gait Clinic at the Mellon Center downtown. That is a 2-week, 5-day intensive program to specifically address freezing. Excellent. Again, cram it all in, get it done, work on it. Seeing really great results working with those physical therapists. And then there's a multidisciplinary gait clinic. So this is great for those people with some really kind of specific gait problems. Maybe they're a little different than what I talked about earlier. Or maybe your needs are just a little different. So this is a half-day program. This is with a PT, a movement disorder specialist, and a physiatrist that can work on trying to figure out what's going on with your specific gait issue. And that's at the main campus. Okay, so what did we learn today? Lots of different gait problems that can happen with Parkinson's. Maybe we needed a device. Maybe we need to investigate that with a therapist. Maybe we need PT to get our individual needs met. And exercise that can show really great results with your walking problems. All right, we're ending a couple minutes early, so I'm going to be up front. If anyone wants to talk, I have my card. I can help get you in touch with your local therapist. So if you have any questions, come find me. Or if you have trouble walking, stay in your seat, and as it clears out, I'll make sure you don't need anything. So thank you so much for your time.